Hello, good morning, everybody. We are back in our studio, our Academy Studio Vitro Life Group at ASRM in Denver. I want to introduce you our next speaker is Dr. Julio Martin. He is our product director. With him, our genetic service, iGenomics. Julio is going to talk to us today about advancing the carrier screening and the clinical implications of carrier screening, focusing mainly on donor gametes. Julio, the floor is yours. Thank you so
Yeah,
much.
thank you. Thank you, Juliana. Thank you for the opportunity to explain the career screening service in Vitro Life Group. Um, I would like to focus this type of service is in the health prevention, and we want to obviously identify who is carrier of certain genes. And I think it is important to also understand that globally speaking, these all Mendelian conditions have a huge clinical and social impact, especially for pediatric admissions and even infant mortality. So it's a global impact. Mendelian conditions have impact in every country and in different healthcare system. The burden, because it means long treatment. We also have the economic impact that we cannot keep out of the equation, but obviously also psychosocial impact, not only for patients, but also for families. So because of this, and the prevalence, again, is important to understand, although these figures in the table may change based on ethnicity or in certain populations, we have to realize that most of us are carrier of something. That carrier rate may vary among the genes, but it's important to identify who is a carrier of which genes. So what is the aim of this type of test? That is like a simple testing of a sample of saliva or blood, and the aim is to determine who is carrier, who typically is targeting healthy person. It's not a diagnostic test, it's a screening test. And the carrier is focusing mainly autosomal recessive, and for female also is linked conditions. Positive findings in both sides, male and female, then has to be compared in what we call adenine match and understand if there is high risk or low risk. We inform the couples about the risk so they can take informed clinical decisions like PTM or even using a different donor. I would like now to introduce what we see in the offer of this type of genetic service. We see that there is like a huge fragmentation in the meaning that there are different panels in the market with different gene content, different size. This introduces complexity because patients may move from one clinic if they not succeed after a couple of treatments, but also different providers or gamete donors may choose different tests from different providers. So this fragmentation, in order to do the matching, you will see scenarios like this one, where in a panel there is not perfect match within the gene content in both male and female gametes. That's why we came with the solution of using NGS and whole exome sequencing. So we are doing the full content in our genome of the gene coding protein genes. We have to complement the NGS technology with other methodology for those tricky genes, but still relevant regarding frequency. I would like to reinforce the message of using whole exome versus targeted panels. When you are doing whole exome sequencing, since we are capturing all coding protein genes, we are having the possibility to report all known clinically relevant genes simultaneously. But we can do virtualization. We can offer different panels based on customization. And that is the opportunity even to mirror any panel in the market, but also we can adapt very easily any new updated guidelines, and or even adjust the gene content for certain populations because we offer the service globally. Due to the capabilities of capturing all the genes, the matching thing is solved, so we can offer matching universally regardless of the test done in the female or the male patient. And also we can upgrade the content. If for whatever reason, because of family history, we reported a panel of genes, we can still offer the opportunity to upgrade and provide additional genes to that report. This is an image representing that capability. If you have two panels with different gene content, and one of them is exon based, you have the possibility to cover the exclusive genes from one side, since we did all the capturing and sequencing at the same time, simultaneously. We define our portfolio based on these capabilities. So we have our mid-range panel, CGT Plus, that still contains more than 500 genes that can be used for both male and female, keeping their own gametes. But also we have the CGT Mirror, that is a panel mainly targeting donors, and this panel can be customized with any panel in the market. We have also the option of using the CGT sequential. In this case, the CGT sequential is typically done when one side, the male or female, is a known carrier for a gene. We can do sequentially updating the information in the donor based on different assignments with different information of positive genes in the patients. And as I say, the CGT Mirror can be used in order to match perfectly the genes that is included for other carriers in the market. I would like to reinforce this message. So if we want to, we always have male and female tested. If we have a donor tested with the exon bias, we report, let's see, the donor report is a mutation report with a defined content. And now we have in the other side the patient tested with any test in the market and is positive for a gene. That gene could be included initially in the donor report. If that was the case, we can see and compare. But if the positive gene in the patient was not included initially in the mutation report, since we already captured it, we can do now the CGT sequential and add that information and then understand if there is high risk or low risk based on the finding in the patient. So we can update every donor facing any report from different patients. So the take-home message for this is obviously that Mendelian conditions are prevalent globally. Carrier screening, the aim is to identify couple of risks, including donors assignment, and since the matching capability, matching is in the carrier screening is fragmented, it can be like a difficulty to match two panels. Using exon-based CGT is perfect and facilitates the matching analysis. So thank you so much.
Thank you so much, Julio, for your presentation. I just want to take the segue that you mentioned about the matching report.
Yeah.
And I want to ask you one thing. Imagine that if patient decide to do their IVF treatment in a different country, right? I'm imagining that we can match panels. You said that here today, and you said that we can match the reports. So could we also allow patients to transition between countries or doing their treatment in different places?
Yes, Juliana. We offer the career screening service globally. So if an international patient has not been tested, we can ship our kits and deliver the CET service globally, or the other way around. I mean, if the patient has been already tested, we can offer the carrier screening for the donor in order to match the panel for the of the patient.
So this is fantastic. If I'm understanding correctly, we are reducing the distance between our patients and their donors.
Yeah.
We are filling the gaps on the carrier screening program with this technology. And I just want to reinforce that goes completely aligned with the three words that are the theme for ASRM this year. So ASRM in this year is saying a lot about equity, access, and innovation. So to close our presentation today, I just want to say that through our innovation, we are being able to bring accessibility to our patients and promote them equity across the globe with our platform. So this has been fantastic. Thank you so much, Julio.
You're welcome.